A lot of our celebrities, young and old, are getting colorectal cancer. We're going to discuss that today. I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We have a guest here, Dr. Carmen Fong.
Thanks so much for having me.
She is a colorectal specialist who has been kind enough to come and join us today to educate us on colorectal cancer and what's going on, why we're seeing so much of it, and why we're seeing it in younger and younger people.
Yeah, no, seriously, it's a concern.
Yeah, and you're obviously at the front lines. You get to see the most of it, so you have like a microscope on it. So how are these people showing up? Carmen, when they come to your office, why does someone go from their family doctor to you because of a fear of colon cancer?
Right. I would say the most common thing is rectal bleeding. So if you're seeing blood in your stool, generally it tends to be like bright red blood. And as we know, most of the time that can be due to hemorrhoids or fissures. But because of the increasing incidence of early onset colorectal cancer, we're starting to be like, okay, basically as soon as you see blood, you either get a colonoscopy, which is like the full scope and with the bowel prep and everything, or at least a flexible sigmoidoscopy in the office, which is a shorter scope, which just looks into the first part, the left part of your colon. Doesn't really require prep. We can do it right away. And as we know, some of the earlier onset cancers are, most of the time in your left colon. So we would find something sooner.
Okay, so like the take-home message right off the bat is, if you see blood in your stool, don't sit on it. Well, don't stall. Go to see your doctor right away. Okay, don't be embarrassed. You've got blood there.
100%.
Go see a healthcare provider to get that.
You're
checked
not
out.
alone. Go get that checked out. And then with that, though, there's also a constellation of symptoms that I like to describe. Unintentional weight loss. So if you're losing weight, but you're not really trying to, abdominal bloating. And then obviously, if you have like a strong family history of cancers or a personal history of cancer or inflammatory bowel disease, as we know, those things increase the risk of colorectal cancer.
So inflammatory bowel disease is like Crohn's or ulcerative colitis, those kind of diseases. If you have those or a family history of those, you should get that checked out. You should be mindful of these red flags, we call them, that you just discussed, and go to see a healthcare provider.
For the record, family history is first-degree relatives or second-degree relatives matter?
First-degree relatives only.
So that's a child, a sibling,
or a parent. That's right.
Okay.
Yep. And so generally, if you're like, oh, my grandmother or my grandfather, that's relevant, but not as relevant in this case.
Okay.
I should also mention change in bowel, change in stool caliber. So pencil thin stools, so having narrower stools are also a red flag.
And the reason that this happens is because your colon is a tube. So if that tube gets really small, the size of the stool that goes through it gets very, very small. So rather than having a bigger stool, that small one is just kind of working its way out. So you still can poo, it's just really, really small.
Right, exactly.
Okay, so those are sort of some signs and symptoms of colon cancer. And now how big a problem is this in our society? Is it a very common cancer? Is it an uncommon cancer? It feels like it's pretty common because we hear about it all the time.
It's actually very common. It's depending on how you look at it, it's either the second or third leading cause of cancer deaths in America. So the third one or the second one being breast cancer, the first one being lung cancer. But very importantly, they're preventable cancer deaths because we have methods to screen for colon cancer if we do it.
Okay, so it's kind of a bad news, good news situation. It's very common, okay? That's bad because it's very prevalent in our society, and that's why we hear about it all the time. The good news is it's very treatable when caught early.
Yep.
All right, that's why we're trying to get everyone to really pay attention to these signs that you talked about so that you can get treatment early, because if you get treatment early, you have a very good chance of being cured from this.
Yes, 100%. So
what is that cure rate, basically, if caught early?
Yeah, so generally for early symptoms, that's why I went into colorectal surgery, is that stage 1, stage 2 disease is actually curable by surgery, right? So generally the cure rate could approach 90%, for stage 1, stage 2, which just means that it's limited to the colon. We remove the colon. You don't need postoperative chemo or radiation, and you're good. In stage 3, stage 4 disease, it can be more like a 65% 5-year survival, which is not as great, but all of these things are actually getting better. We have more chemo, more radiation, more liver surgery that we can do to remove metastases, all of that. I think I just wanted to point out, though, that there's the difference between screening colonoscopy and diagnostic colonoscopy.
Okay.
Right.
Okay. All right, so we're kind of...
So before you do that, let's say patient's in the office.
Yeah.
You took the history. And the other thing I'd say about stool is, what if they have a black stool? Because we all talk about the bright red blood. That seems obvious. And thankfully, 90% of the time, it's actually not cancer.
Correct.
What if they have black stool, though?
Yes.
What does this tell us about what's
So
happening?
black stool means that it's blood that's being digested further up your GI tract. So in those cases, it can be that you're bleeding in the right side of your colon. It's taking longer to get through your colon. And so by the time it gets out, it's not bright red, it's black. And so black tarry stool is also a symptom that we should be worried about, a sign.
Okay, so we've you've got some of these symptoms. We've seen these red flags that we just talked about, sort of how you're feeling, your weight, your stools, and we told you that you're going to go see your doctor. With these signs and symptoms, we told you what you're worried about and what the doctor's worried about is colorectal cancer or some kind of colon cancer. We told you so far that it's very common, second or third most common cancer. However, when caught early, it's treatable. So now that you're in your doctor's office, you know all this stuff. What are the investigations that are done to determine, hey, do I have colon cancer? Do I have rectal cancer?
And the exam, can you feel it?
Yes. Well, if it's large, yes, but very rarely can you actually feel it. So I would say most of the time you can't feel it and you don't want to be able to feel it. Obviously, we still start with a general exam, history and physical, get all of the information that we need, listen to your heart and lungs, palpate the abdomen. We will still do a digital anal rectal exam for these cases just because that's what we do. And then colonoscopy.
Is the stat about the digital rectal? I remember doing Gen Surg rotations, they're like 50% of rectal cancers you can actually reach with your finger or within reach of your finger. Is that an accurate statement?
That is actually true.
Okay.
Yeah, that is actually true for rectal cancer, right? So I think. And
I was always told there are only two reasons to not do a rectal. Is that if you don't have a finger and the patient doesn't have an anus. Essentially, if you're on a general surgery rotation, you better do a digital rectal exam because it's like you said, low hanging fruit. Like it's easy to diagnose. Like if you miss that, it's kind of indefensible, right? You gotta find
inspection. Inspection is just
it's part of your physical exam, and I think that people get a little squeamish about it, for sure. But it's easy to do, and it's like it's a sensitive exam, so the patient gets uncomfortable, but you just explain to them that this is part of the exam. Just like if I listen to your heart and lungs.
Dentist looks in your mouth all the time.
Exactly. The other, mucosal entry point.
Okay.
Right?
Okay. So you've done that exam, you've done the physical exam, the history. Okay, let's go to the tests. Where do we start?
Right. So I think that especially if you are in the ER, you will end up getting a CAT scan for sure. But that is technically not the first, diagnostic test. You want to get a colonoscopy. So a colonoscopy with a full bowel prep means that, again, you kind of clean your bowels out and then you go get a full scope of your colon. We're looking at the inside. This is both diagnostic and therapeutic because we can see inside, and if there's any like polyps that are bleeding, we can remove them, right? And that's as opposed to like what we call a virtual colonoscopy or CT colonography these days, where you can get a colonoscopy, they can do a 3D reconstruction of the inside, see the polyps, but then you would still need to get a colonoscopy to remove the polyps and tumors and things like that.
And this is in an elective setting, so you plan it, you get the prep, you come in, you have the test. How far can you go with the colonoscopy, like in the colon? Like can you get into the ileum? Can you?
Technically, you should get into the ileum, right? So if you get into the ileum, that makes it a good colonoscopy. You want to go through the ileocecal valve, which is at the end of your right colon, and just into the terminal ileum, so just about the point where your appendix is. You can see the appendiceal orifice.
If you see a molar, you've gone too far. Okay, so colonoscopy is going to be the diagnostic test that you're going to do to see if someone has colorectal cancer. And then let's say you do find it.
Yes.
All right. So can we jump into some treatment options?
Yes. So then you find it, you biopsy it, and then we send it to the lab. It takes 7 to 10 days for us to get the results back. They tell us it's cancer, right? So they tell us it's adenocarcinoma. And then there's a bunch of things we have to do before even treatment is we have to stage. So it's very important for medical students, residents, like always stage on your oral exams, right? So do the staging first in colorectal cancer. It's going to be a CAT scan of the chest, abdomen, pelvis. You want to make sure there's no metastases in your lungs, which is the most common area, or in your lymph nodes. And then after the staging, you also want to do a series of blood work. So you want to do CEA, which is a carcinoembryonic antigen.
Okay.
CEA. CA19-9, CA125. So common tumor markers in the blood test that show us your baseline, but also if after you're treated, those numbers should go down on your blood test.
Okay, so staging in this sense, a little bit different than in theater for those theater buffs. Staging, when we're talking about staging, we're talking about trying to determine, is that cancer that we just saw on the scope, is it just there or has it already spread other places? Because the prognosis and the treatment is very different if it's just there or if after staging, we say, oh, it's also spread to other parts. So you need
Right.
other kinds of treatment.
Right, exactly. So that's why we need to know. So again, for stage 1 and 2, which is really just limited to inside the colon, surgery can be curative, especially for colon cancers. We remove that section, put that section of colon back together. Basically, you're done. You do need to have like, annual surveillance, with colonoscopy, with imaging, things like that. But you don't have long-term chemotherapy. For stage 3 and stage 4, you definitely need to start with either chemotherapy in colon cancer, and then in rectal cancer, right? You actually start with chemotherapy and radiation.
Okay.
So you're going to shrink the tumors in the rectum before you go to operation these days.
So stage 3 is local metastases, and then stage 4 is distant metastases.
Yes, thank you.
So,
Yep.
Okay. So 2 questions for the colonoscopy. So if you get in there, I'm assuming every now and then you have a lesion or a cancer that is so big that you can't go any further.
Yep.
So you're like, well, this person, we have to
Yep.
stage them now, but there could be, I'm assuming there could be other cancers beyond that.
Yes. Yes.
So how does that work for them? And another one is, if you have something really small, do you ever say, well, listen, let's just remove this polyp
Yes.
as not only diagnostic but also curative?
Yes. Yep. So let's start with the small one because
Okay,
that's slightly
makes more
easier. So,
sense.
Yeah, okay.
so you can do like endomucosal resection and remove that polyp, and basically as long as you get the bottom of it as well and you have clear negative margins, that can be, curative for that, for that cancer.
Like a tree with the roots. You
Yes.
can't just cut it off and leave a stump. You
Yep.
ideally want to
You're
get
gonna
the roots
take
out.
the roots out
Okay.
essentially.
Of the polyp.
Of the
Of the
polyp.
polyp,
Yeah,
yes.
take the roots out. You don't want to just cut it off at the neck or the limbs.
Right.
Take the roots out and you're done for that one.
Okay.
As long as there's no other lesions. Larger cancers that are obstructive, I think that's a better question. So you can do a couple things, right? You
Okay.
can biopsy and then get out. Go to the OR.
Right.
The more common thing right now though is to biopsy and stent. So you can leave a stent in it, stent it open so that you can actually get a proper bowel prep and then try to scope the rest of it at a later date on the same hospital admission.
So through the stent with your
Yeah,
camera?
through the
Oh,
stent.
interesting.
Yep. Yeah,
Okay.
or at least be able to bowel prep so that when you go to the OR, you don't have like a super
No
distended colon.
surprises.
Yeah.
Oh, interesting.
Right.
Okay.
Worst case scenario, we end up in the OR anyway, and you're just palpating.
Right, you run the
Right.
bowel.
You run the bowel.
Right.
Yes.
Okay.
Yep.
Okay, so there's going to be some surgery involved if you do have this. However, if it is a low stage, great news. It's very, very high cure rates
Yes.
with the low stage.
Yep.
Higher stage, cure rates aren't as good, but
Yep.
still treatment available.
Very
with-
available.
with still a reasonable cure rate available. to
Yeah.
you.
Yeah.
All right, can we talk a little bit about screening? Okay,
Yes.
because this
So
is such a common cancer,
Yeah.
and because it's so important to catch it early,
Mhm.
because your outcome is so good if you catch it early, we developed these screening tests.
Yes.
What's your recommendation for screening for this? If you're out there,
Right.
someone's out there watching, I have no symptoms, but I'm really worried about this now because I saw this video.
Yeah.
What are some screening tests available to me?
What I would say is, you can even give us your society's recommendations,
Yes.
and then what you think would be a better
What
to
I think
trend
would be better,
towards in an ideal
100%.
world.
Yes. Yeah. So the U.S. Preventative Task Force recommendation is now that we start screening colonoscopies at age 45.
Okay.
It's down from 50 from a few years ago, which is an excellent, kind of advancement, but I think not quite low enough. So screening starts at 45, which means that if you have no symptoms at all, you go in, you do your colonoscopy prep, you get your colonoscopy, even without any symptoms. And the reason we do this is that we know that colon cancers start from small polyps, right? So
Right.
they start from smaller polyps that advance into bigger polyps and start growing. So if we catch it at an early stage, we can kind of just cut it out, we're good, and then screen every few years. There's also a couple other tests.
Sorry, just for the viewers,
Yeah.
can you tell us, so if they have such a negative or a clean colonoscopy, what would be the frequency and duration? Is it like every
Yep.
5 years for the rest of their life? And then if you have a polyp, or you had something really small that wasn't even needed treatment, what
Right.
would the timeline look like
Yes.
for people?
So completely clean, you
Yep.
get one every 10 years.
Okay.
If you
bad.
have, which is not bad. If you have 3 or more polyps, you actually do one every 3 years.
Okay.
And then somewhere in between 1 and 3, you actually do one every 5 years, right? And then if you have a family history, though, I've seen a lot of people kind of like vary on their screening, protocols. And so if you have like a strong family history of like IBD, colon cancers, you might end up somewhere between 3 and 5 years.
Well, so it's not too bad. right?
No, not too
Okay.
bad. There's other options,
Okay, let's
for
go.
screening, which is you can do a flexible sigmoidoscopy every 5 years
Okay.
with a fecal occult study. So you're seeing that first section of the colon and then, doing a blood test on the card. It's not as great, you're not catching as many things, but it's better than nothing.
What percentage of the cancers would be from essentially the anus to the sigmoid colon that you can see, and then
Right.
what percentage are beyond, like transverse? And,
Right. So transverse is minimal, but I would say actually it's probably 30-40% in the right colon,
Okay.
and then about 60% in the left colon and sigmoid. Rectal cancer tends to be like a whole other thing.
Do we know why it's on the transverse? Seems
we
weird, right?
don't know.
There must be something unique about it, I'm assuming.
I think it's a bit of
I
a
wonder
thinner
if it's
wall
because
there.
things don't sit there,
Yeah,
'Cause
you're
I
either
think-
going up or going down. You don't,
Right,
you don't
yeah.
hang out on the flats.
And things we know on the left colon is because there's more irritation, like things sit there for longer
Right,
periods of
waiting
time,
to
and so
leave.
you have that suck-in, suck-in injury.
Yeah.
You have the genetic predisposition, and then you have like the suck-in assault of the
Okay.
irritation. Yeah.
And the sigmoid, that doesn't require that big bowel prep that you.
The sigmoid does not. I mean, you can, a little enema if you can, but if not, you can still actually see most of it in the office without any bowel prep.
Okay.
Yeah.
There's a bonus.
Right.
For those
And
of
then
you who've
fit
done a bowel
tests.
prep.
Yeah.
Fit test. Okay.
Fit test.
FIT test.
Yeah,
Okay.
fecal immunohistochemistry test every 1 to 3 years if you can. And that is a good study. Those, there's actually no age guideline in the US, but I think they should start at 25. That is
Okay.
my personal opinion.
Fit test at 25. Okay, there's an
Yeah,
opinion. I think
right.
in Canada we're 50, I believe.
Yeah,
After
Right.
50,
Which
you
is
get a-
still too late.
Yeah, 50 a fit test every 2 years. And
Yeah.
a fit test, will that pick up a polyp or only a cancer?
It will pick up larger polyps
Oh, really?
generally. Yes. So
Okay.
because you're testing for the DNA that's abnormal, and so very small polyps won't start producing, but a larger polyp, yes.
Because they're shedding essentially
They're shedding cells.
Okay.
Yes.
Okay.
Yeah. Right.
All right. And fit test is just where you take some stool and you send it into the lab
Correct.
and then you wait
Yep.
a while and they mail you
Yeah. You
back
kind
your
of put it on
results.
a card.
Yeah.
Yeah.
Yeah, you put it in the mail.
You put it in the mail.
Yeah.
I mean, and I always tell patients like sometimes that's harder to do because like you have this card sitting on your counter and you're like, I'm gonna do it tomorrow. I'm
Yeah.
gonna do it tomorrow.
Yeah.
Like no, just do it because
it.
it'll be a year and you'll forget.
Yeah.
Just do it. And
Yeah,
so-
do not lick that stamp, whatever you do. Okay, so that's the fit test and colonoscopy. Those are the two real mainstays of
Correct.
screening
Yes.
for
Mhm.
colon cancer. If
Yeah.
you have that available to you where you
Just
live,
do it.
you should just do it.
Just
all
do
right?
it,
Or if
yeah.
you can afford to do it, if it's not available to you, really, because
Right.
like we said, colon cancer, when caught early, the
It's
cure rate
preventable.
is so good.
Yeah.
Whereas later stages, it still has a decent cure rate, but not as good as if you catch it early.
Just one thing, someone's going to type of comment for sure.
Yeah.
Oh yeah, you're a surgeon. You make money from doing surgery. You're telling us that we should get colonoscopies every 20 minutes. Are there any downsides to getting a colonoscopy?
Yeah. No, that's a
What-
great
what-
question.
We always say, hey, doesn't matter what we do, even if it's as benign as it can be, there's still always risk.
Yeah. 100%.
What are the associated risks with having a routine colonoscopy?
Yeah, no, and I always say we have to, weigh the risks and benefits. So, I would say the general risks are, there's risk of general anesthesia. There is a risk of perforation, right? So, a colonoscopy that's a little bit too rough can go right through the colon, and you can get things like, essentially burst the colon and have like, bacteria in your abdomen and get really, really sick. It's rare. Like
Right.
it's usually about like a less than 0.2% chance. They actually did a study on this. It's rare, but it can happen.
Yep.
And then obviously the biggest risk I would say is actually with the colonoscopy prep. So, doing those 4 liters of electrolytes, you're in the bathroom for like, 24 hours and people can get super dehydrated from it. So I generally recommend, drink your Gatorade, kind of like do your other electrolyte solutions if you can while you're doing the colonoscopy prep. I mean, I would do colonoscopies all day if it would prevent cancer,
Right.
even whether or not they paid me.
No, yes, no,
No,
that's what happens.
100%.
They're always like, you guys are big pharma
Yeah.
shields or whatever, you're
Yeah.
surgeons, blah, blah, blah. We're like, we just report
Yeah.
the results.
No,
and,
I
and like
think
we've
that's
always
a-
said, you get to decide what you do, but
Uh-huh.
you should be, Paul and I have talked about this a lot recently, you should be the one that cares the most about your health because it's
Right.
your health.
Right.
We're just
And-
giving you the tools.
Yeah, and people will be like, oh, screening seems so like unnecessary. Like if a clock broke, like why fix it? But you really want to get there before the clock breaks, right?
Yeah.
Yeah, screening tests are, and they're not just developed willy-nilly. People have put some thought into it to see, how many of these tests
Millions
we
of
have to do before
Yeah.
we catch something. So if your government or wherever you live says this is a screening test available to you,
Yeah.
take advantage of that because it's
Yeah.
been investigated and shown that, this is helpful to the population.
Yes, no, it actually does work. And I think the screening uptake in the US is like 67% right now. So like there's still a lot of people who aren't getting their screening done,
Right.
which I think is where we're kind of like, missing the boat. on a lot of the colon cancers.
And then lastly, we always talk about prevention.
Mhm.
Anything people can do to not remove all of their risk, but try to reduce their risk. Like, who do we
Yeah.
know, hey, if you do this, you're going to increase your chances of getting colon cancer.
Right.
And nobody wants that.
Right. No, it's a really good question. Like a lot of studies right now, right, especially with the early onset, which we know like the rates have doubled, you know, in the last 10 years.
So that's a real thing.
Yeah.
What you're seeing is real. There are more cases of it, and in younger people.
Right.
You're not just imagining this.
No. So the rates for older people, like 50 and above, are actually going down, while the rates for like 50 and below have doubled from, I think it was 6% to 13% in the last 10 years. So literally doubled. And we think it's a lot of, you know, honestly, diet and exercise are the main things we can point to right now. So gut dysbiosis, presence of like E. coli bacteria like early in life, or possibly like antibiotic associated. Did I say microplastics already? Like possibly
No.
microplastics, but also like this diet and, you know, sedentary lifestyle where we're eating like a lot of processed foods and not being active. So staying healthy in general is going to help.
Okay,
Yeah.
asking for a friend. Alcohol, is that, what's your take on that?
Yeah, you know, drink in moderation, like everything in moderation. So alcohol is not specifically linked to colon cancer. It has been linked to breast cancer. But I would say drink in moderation because there's other like, you know, downstream effects, right? There's inflammation that can happen in your colon. You can have like more diarrhea or constipation from, you know, excessive alcohol use. You can have like liver problems from excessive alcohol use.
And then the last one, we hear lots about highly processed meats, and that they are probably carcinogenic. And then the one that kind of gets lumped in with it, and a lot of people are angry about it, is the red meat side.
Right.
That this might be carcinogenic.
Yes.
Where is the data currently on red meat and whether or not it's related to colon
So
cancer?
specifically red meat, it's really like the, you know, the grilling part of the red meat that makes it carcinogenic. So like if you're grilling and you're eating a lot of the char, like we know that is
Makes
bad
sense.
for you. I know it's
my
like if you
favorite part.
only ate, I know that's the tasty part.
Yeah.
If you only ate red meat, that would probably not be a good thing. And then in terms of deli meats, like, you know, having a slice of, you know, turkey on your sandwich like once a week or once a day is not going to be bad for you. But if you ate it like in excess, like literally only ate, you know, deli meat, only ate like, you know, strongly cured like salamis and stuff like that with a ton of nitrates in it, those are the things that are going to be like more carcinogenic.
Excellent.
Yeah.
And then
Hot
I saw
dogs.
somewhere
Hot dogs, yeah.
online too. I never saw any evidence to support this, but having had a cholecystectomy, does that increase your risk at all? So having your gallbladder taken out.
Yeah, no, you know, I saw that online too. No, so far that has not been shown to increase your chance of colon cancer. But, you know, you actually can have post-cholecystectomy syndrome, which increases your diarrhea and constipation rates. And so, again, maybe downstream effects.
It could alter your gut microbiome potentially.
Yes, yeah, alters your gut microbiome, alters your bile acid, you know, movement and flow.
Okay, guys, so take-home message, take-home message. Colorectal cancer is common, okay? It's happening more and more in younger people. It's very curable, if you catch it early, and there's a lot of screening tests available to you to help detect it early. You're not going into this blind.
Yeah.
So if you feel like something's going wrong, see your doctor. If the screening test is available to you, whether it's a blood test or a stool test or a colonoscopy, take advantage of it.
Yeah.
Now you
Go
know.
get screened.
Yeah.
Go get screened. And if you like this video, please like it, subscribe to our channel, share it with someone that you know is thinking about colon cancer and debating whether or not they're going to have their colonoscopy.
And remember, you are in charge of your own health. Thank you so much. We're going to put all your links in there so that anybody wants to come and see you and talk to you more about this in your clinic can do so.
Yeah, thanks for
That's
having me.
That's awesome.